Hello, can you hear us?
Yes, Dr. Michael, we were waiting for you. Yes, thank you.
Okay.
Yeah,
Thank you.
we're
Yeah.
just starting. So, hello everybody. Good evening, good morning, and good afternoon to everyone who has joined from across the globe today. So, to yet another session on advances in thalassemia care, which is being jointly organized by the Thalassemia International Federation, Thalassemics India, and the Postgraduate Institute of Child Health. So today's session, we focus on bony morbidity in thalassemia. So as you know, bone pain and skeletal morbidity remains one of the most prevalent and under-addressed complications of thalassemia. And it contributes a lot to the functional limitation as well as pain and quality of life, poor quality of life across adolescents and adults with thalassemia. So despite all our improvements in transfusion chelation, these are concerns which musculoskeletal concerns are something which we do not address effectively. And so that is why we thought of having this session today. And the session for the introductory overview, I would request from Thalassemia International Federation, we have Dr. Michael. So the Dr. Michael Angastinoitis is the medical advisor of Thalassemia International Federation. I would request Dr. Michael to kindly introduce the topic and the context of this session today. Over to you, sir.
Okay. Thank you very much indeed. First of all, I'd like to congratulate Dr. Nida and her team in Noida for organizing these webinars, which are extremely useful. And today's subject in particular, bone pain. As she has said already, bone pain is a direct, if you like, insult to the quality of life of our patients, especially in adult life. The problem probably starts from very early childhood because low hemoglobin levels allow bone marrow expansion, destruction of bone architecture, microarchitecture from early life, and we find it difficult later on to correct this. So however much we try to rescue and correct osteoporosis later in life, probably the problem starts very early. So pediatricians stay alert because it's in your hands, perhaps, to help prevent this issue. Certainly, in my experience, I don't know many thalassemia patients who are adults who do not suffer from pain. So this is an almost universal issue nowadays. I'm not going to say any more because that will interfere with the other speakers. But just one final word. Let me apologize for the fact that I'm replacing Dr. Andrea Eleftheriou, who has been called to another duty. Thank you very much indeed. And Nita, over to you now.
Thank you, sir. So, like you rightly said, this is one of the things that is actually directly related to the disease rather than to rather than due to chelation or iron overload and all the other issues that we see related to thalassemia care. So now, for the context setting in Indian scenarios, I would like to invite Dr. Deepak Chopra. So Dr. Deepak is, Sri Deepak Chopra is the president of Thalassemics India. And he is an active advocate for patients with thalassemia. Thalassemics India is one of the organizations. It's a national NGO which has been working towards advocacy and improving government policies for patients with thalassemia. And his key role is in blood transfusion safety, transfusion policies from the government, etc. Over to you, sir, for the introductory remarks.
Thank you, Dr. Nita. First of all, those who are joining from the other part of the country, or the world rather, I would say good morning to you, because we are almost coming towards our evening. Some of you have interacted with those in the panel today. It's my first introduction privilege to be on a face-to-face virtual with Dr. Michael, with Dr. Poggi, Dr. Ashima Dabas, and Dr. Bhattacharya. As far as Dr. Neeta is concerned, we have had interactions on various occasions. It's very heartening that ECO, PGCH, PGICH, and TIFF, along with Thalassemia India, have thought of these webinar series. And each time you pick up a topic for care of thalassemics. While it is very heartening that you have picked up a subject of bone pain in the adult thalassemics, same side, it is also very disturbing that we are still struggling and fighting, battling with transfusion transmitted infections such as HIV. And it has been just in the last 2 weeks that in 2 states of the country, children who had gone in for transfusion have landed up with HIV because of, let's say, non-NAT tested blood, or otherwise we don't have the detailed report yet. So I would say that, well, this subject which has been picked up for today's webinar has been neglected to a great extent. Why I say neglected is that it is very unfortunate that, in early stages, when the thalassemics are in the age group of, let's say, between the age of 10 to 20, when they are under a pediatrician, some symptoms should have been picked up at that time itself. There should be some system whereby in their monthly checkups or whatever, one is able to pick up and see and put the child on to preventive. I don't know if there is some sort of a preventive in this case, but we find that now today in India, we have children who are grown-up adults and they are in the age group of even 50 plus. Now in 50 plus, these adults are still being looked after by pediatricians who do not have much info or much experience of issues like bone pain. Frankly speaking, there has never been, or there has not been rather, a transition or a handover from the pediatrician to either an endocrinologist or a hematologist or a rheumatologist to look into these problems and these issues which crop up because of multiple transfusions and other issues that are faced by these children. Now, I am of one opinion that these sort of webinars or interactions should include adult thalassemics, because it is they who can explain and put across the difficulties or the type of hardships they are going through, so that the experts who are in our panel or who are attending this sort of a webinar can come up with some suggestions or a line of action as to what sort of a protocol or what sort of a medical plan has to be put across to see to it that these adults who are otherwise now robust because they are going through timely transfusions, but are landed with these added problems. So I would say that, well, this seminar or this webinar must address and must have adult thalassemics to participate, to be not only as dormant listeners, they must interact. I do not know as to what is the practice overseas, be it in Italy, be it in Cyprus, be it in other parts of the world. But as far as India is concerned, and I can definitely say for Delhi, we do not have a panel of doctors from either endocrinology or hematology or rheumatology who would say that, well, let's look into these 1 dozen or 2 dozen cases of adult thalassemics. So I would suggest that if this today's interaction could come up with some sort of a small action group of these specialists who could be either in Delhi or outside Delhi, but today technology can connect you wherever you are in any part of the world. But we must come up with a small action group for these adult thalassemics, wherein they can fall back on this group for any interaction or for any clarity or any area which still does not have a proper approach as far as treatment or medical plan is concerned. With these few words, I would once again thank each one of you for having spared your time. And I sincerely hope that the point which I have made gets registered and you will look into it for further action. Thank you once again.
Thank you, sir. So now going to, usually in our programs, we have an international expert and an Indian expert. So I'll briefly introduce both our experts today. It's our privilege to invite Dr. Mauricio Poggi, Professor and Chair of Endocrinology at the St. Andrea Hospital, Rome, Italy. Dr. Poggi is an internationally recognized scientist for his work on endocrine and metabolic complications of thalassemia, particularly disorders of bone health. And in this session, he will be addressing the pathophysiology of bony pain, bone disease, and how we can identify and what are the evidence-based approaches for prevention as well as treatment. Following Dr. Poggi, we'll have Dr. Ashima Dabas. Dr. Anju, who was scheduled earlier, could not join due to some last-minute health issues. So we have Dr. Ashima Dabas. She's a professor of pediatrics and in charge of the pediatric endocrinology unit at Maulana Azad Medical College in New Delhi. It's one of the largest public sector hospitals in New Delhi. And Dr. Dabas will be focusing on the Indian scenario, as in the clinical presentations in India. What are the what are the diagnostic algorithms that are followed in Indian scenario, and what are the daily challenges that we encounter. So after this, we have a brief case discussion and we have a lot of questions to our experts. So now I would request Dr. Poggi to start his talk. Over to you, Dr. Poggi.
Here I am. Good evening to all. Thank you. I'm trying to share my desktop. I hope it's okay.
Yes, we can see it clearly. Thank you.
Okay. Thank you. Thank you for the kind introduction. Good evening to everyone. It's really a good pleasure for me to be here. Thank you for the opportunity. Task of my presentation will be on bone health in thalassemia, and I have nothing to disclose. and this is my summary. I would like to start from a brief introduction, what we should know about hemoglobinopathies. We have to remind us that they are the most important inherited disease worldwide, with a prevalence that varies across countries. And we have also to keep in mind that prevalence is changing according to globalization and higher flow of migration. But we also keep in mind that high socioeconomic costs should be taken into account in the next year, considering also the high number of patients that we need to treat. The disease is really changing the last decades, and thanks to chelation therapy from the first one, the ferroxamine, and thanks to oral chelating agent like deferiprone and deferasiros that give us the possibility, as we heard in the introduction, for one of the most important goal in our activity, to improve the quality of life of our patients. The quality of life of our patients is really changed thanks to newer chelating agent, but nowadays we have to face with another task. We have to face with endocrine damage that could be really large, as we can see in this slide. We can face with pituitary disorder, with thyroid and parathyroid deficiency, with the pancreas impairment, with diabetes, with hypogonadism, and core of my presentation with osteoporosis and bone tissue impaired health. The etiopathogenesis of endocrine damage is obviously related to higher overload, to anemia and chronic hypoxia, but we have also to remind us the real importance of delay in and low compliance to chelation therapy. We heard some minutes ago that those patients live longer and live with a better quality of life. And nowadays, as in this very recent paper, we can see how comprehensive endocrine care is really important. And as we can see in this table, the endocrine axis impairment are really large, and the bone disease, the prevalence rate data of bone disease is nearly 50%. But some words about the prevalence rate, about numbers. This is a paper that we wrote some years ago, and you can see, for example, that in the same population, the prevalence rate could be quite different. We have to remember that the numbers could be really different in order to the different mean age of the population evaluated, but also in relation to the different tools that we could use. This is a slide that I love and that give us an idea of how much complex, how deeply is the impact of endocrine status on bone health. We can see how is important GH-IGF-1 axis, parathyroid and thyroid function, gonadal status with estradiol and testosterone. All these hormones are really important with direction on osteoblast and osteoclast that are the main cells that are involved in bone tissue health. Obviously, without forgetting that also anemia and iron overload, main actors of the disease, are really important in bone resorption and new bone tissue formation. A step back to the prevalence rate, we can see from this other paper that prevalence rate for osteoporosis is quite high, always nearly 50-60% of patients evaluated. But I would like to focus on an aspect that I think is really important, and is the fact that also the prevalence rate of osteopenia is really important. And we have to remind us that in this clinical context, we are speaking about a secondary osteoporosis, not an osteoporosis state like we face in general population, such as in women in postmenopausal age. And this is really important because also in osteopenia state we can face with the main event that a patient could face, fracture. Fracture prevalence is quite high also in age in which usually there isn't. We can see in this slide that the mean age of fracture is quite young. But try to give you some practical advice about our activity. I would like to connect with really recent guidelines from Thalassemia International Federation. And in the chapter 6, we wrote about, first of all, one aspect that I think is really important. We have to check all the secondary factors that could be important in the bone health. And first of all, we have to check for the presence of hypogonadism. And regarding hypogonadism, I would like to share my experience. This is a recent work that we presented in our National Congress some weeks ago. And in our unit, in a population of nearly 400 patients, we can see that the prevalence rate of hypogonadism is quite high, nearly 40%. But most important, we can see that patients affected by hypogonadism show a higher prevalence of osteoporosis. How we have to study bone tissue in our patients? The guidelines remind us that the gold standard is the measurement of BMD by DEXA. DEXA is really important to give us an idea of bone health. It could be useful an assessment of fracture probability to identify those patients that are at high risk of fracture. And we need to identify all those potential modified risk factors that could contribute to bone fragility, like vitamin D deficiency or hypogonadism itself. The guidelines also remind us a strong message about the need of a start in adolescence, a start as soon as possible, sometimes also earlier, starting at 10 years of age. DEXA is not the only tool that we can use to study bone health, but is the best. We can also use TBS, RAMS, or CT, but as you can see in this table that I adapted from the recent paper that is at the bottom of the slide, DEXA is absolutely the best way, also because for other tools we have to consider that we have limited data in thalassemia patients, and we are also concerned about higher cost. In conjunction with the DEXA evaluation, we have to study our patient with a deeply serum evaluation that check balance between anemia and iron overload, that check calcium phosphate, kidney function, PTH, vitamin D, and 24-hour urine calcium. Obviously, another check of gonadal and GH-IGF-1 axis status, and not in all patients, but in selected cases, could be really useful the evaluation of markers of bone turnover. But going to the treatment, I think that milestones of treatment in patients affected by thalassemia are three. We have hematology, endocrinology, and lifestyle. From an hematology point of view, I think that the most important fact that we have to perceive is an adequate transfusion to suppress ineffective erythropoiesis and give to our patients an effective chelation to reduce iron overload that we saw is really important for the bone. Speaking about endocrine treatment, vitamin D is usually the first step. Guidelines remind us that we have to check the serum level of vitamin D. We have to check the level that is optimal between 30 and 50 nanogram per millimeter. In all cases in which there is an insufficiency or a marker deficiency, we have to supplement. But a good question is what kind of vitamin D supplementation we have to use. Usually, the gold standard for supplementation is a cholecalciferol, but we have also to remember that our patients are patients with many comorbidity, are patients affected by a chronic disease, and sometimes we can face also with kidney and liver disease. In those cases, we can use other vitamin D like calcifediol and calcitriol that could give us a better result. Another good question is about calcium supplementation, if we have to use a yes or no. We have to remember that the goal of data intake regarding calcium is about 1,200 milligram per day. Data intakes is always the best way, and especially in thalassemic patients, because in thalassemia we frequently see hypercalciuria. You can see from this table how it could be easy to achieve a good intake of data intake, and this is something that we have to speak about with our patients. When sometimes data intake is not feasible, obviously we have to supplement, but there is a good way to do it, no more than 500 at a time, and calcium carbonate is probably the best option. But after vitamin D and calcium, many times we need other drugs. And the first step are represented by antiresorptives. We have two kinds of antiresorptive drugs, biphosphonates and denosumab. Data on biphosphonates are good. We have more data on this kind of drugs. For example, in this paper from Indian colleagues, we can see how the use of zoledronic acid, intravenous zoledronic acid, is capable to give us a good results in terms of improvement of BMD, both at lumbar and neck site. And the same results you can find literature, as in this recent paper, in which we can see how oral alendronate and oral biphosphonate could give us a good results in terms of improvement of bone marker turnover, and also, more important, we heard about it and about its importance in quality of life of our patients, a good improvement in back pain and bone pain score. Unfortunately, data on denosumab are scarce, are very rare in literature, and is not like in general population. This is a paper that I find that give us how denosumab could be a good actor to use, is capable to give a good improvement in bone mineral density, especially at lumbar site, and also, like biphosphonates, a good improvement in marker of bone turnover. Many times patients ask us about the risk of drugs. We have two main risks, hypocalcemia and ONJ. Regarding the first one, we have to remember that is needed an accurate check, and we need to correct serum level before to start therapy with calcium and vitamin D. Regarding osteonecrosis of the jaw, we have to speak with patients, and we have to speak about the fact that it's a serious event, but it's really rare. Is more frequent in patients affected by diabetes, or more important, in patients that are current smokers. A good way is advice about a dental check before starting therapy, and reinforce advice about good oral care and a regular dental check. We have also other drugs like anabolic drugs like teriparatide that we use from about 10 years, more than 10 years in general population. But unfortunately, in patients affected by thalassemia, the data they are very scarce. And we have also more reports about low tolerability. Also, in my experience, I treated about 12 patients with teriparatide, but only 2 out of 12 finish the scheduled program. And this is related to back pain, to flu-like syndrome, especially. We hope in better results from future shots like romosozumab and baloparatide, but in this moment we have absolutely no data. And we are also to speak about a warning about romosozumab regarding the possibility of MACE. What about the future perspective? Probably the future perspective could be a different use of therapy. The future should be personalized, probably using an anabolic agent like Romo or teriparatide to be newborn, followed by an anti-resorptive drug. But probably better results could be achieved using in the same time, in the same moment, anabolic anti-resorptive drugs. But at the moment there is no data, and there is another fact, another problems that regarding reimbursement aspects that are lacking and that are obviously crucial for the application process. Some minutes about lifestyle that I think is really important. Really important because could give us better results and could be easier to achieve at a lower cost. We made a revision of our population. For example, we can see how in our patients, osteoporotic patients, showed a higher frequency of car smokers and a higher frequency of patients with a low physical activity. We need to stress about this aspect. It could be really, really important. And we are near the end of presentation. I would like to share with you some take-home message. The first one is obviously the fact that hemoglobinopathies are really important, especially if we consider the prevalence rate in the world population. High regulation therapy has changed the course of the disease, and now patients live longer, live with an improved quality of life. This is a fact, likely. But nowadays we have to face with a very critical challenge that is regarding endocrine and bone tissue damage. We need, as guideline remind us, we need to start early in evaluation, we need to start early in lifestyle evaluation, and we need to stress in every consultation about an improvement in lifestyle and an improvement in the adherence to hematological therapies. Endocrine status should be regularly checked and optimized if needed. We need to use the right tools. We need to use the right tools to assess bone status. The first one is DEXA. X-ray could be useful. We need to conduct a good serum evaluation. Vitamin D and calcium, not at all, but when required, are the first pharmacological steps to improve our bone health. And after that, anti-resorptive drugs are effective, but should be used with caution. At the moment, unfortunately, we have no data, and the few data are also sometimes not good about the use of anabolic therapy. But I think that the most important the most important message about treatment of patients affected by thalassemia is about the needs of a team that share the experience and most important, share a continuous coordinated full communication. And I would like to go through the end of my presentation, as I usually do, with some videos that give us how our team should be, as in this video, in which we have all skilled figures everyone is in the right place, everyone with a clear-cut task, but most of all, with a clear and full communication. Sometimes we can see team with the presence of dedicated, skilled figures, but the communication is not so good. And when it happens, the patients, in this case, the driver, is there waiting for an answer. I hope that the worst situation in which the skilled figures are not present is not in our daily practice. And I would like, at the end, I would like to thank all the colleagues and friends that work with me in the Thalassemia International Federation guidelines. I want to thank the TIF. I want to thank the Italian Society for Thalassemia, all the patients in the association, and most of all, I want to thank all the colleagues, nurses, trainees, my mentor, all those people that give me the opportunity to grow up in this exciting journey that has lasted from about 24 years. Thank you a lot for your attention.
Thank you very much, Dr. Poggi, for that very concise description and the beautiful analogy of the F1 racing, how everybody should be at their positions waiting for the car to come in and get the repair works done, because that's how we should be ideally in managing chronic diseases like thalassemia, because everybody has a part to play and everybody's part is equally important as well, and we should be ready with our part when the patient comes in. Thank you for highlighting the surveillance strategies, the how to manage, what are the steps of management and how we can prevent, and including the lifestyle changes. We'll take up questions at the end of the panel discussion because we have quite a lot of questions for you and Dr. Ashima. So with this, we can go on to the next talk, which is by Dr. Dabas. So Dr. Ashima will be discussing, as I mentioned earlier, we'll be discussing the Indian perspective as to how patients present in India and what is the prevalence and what are the management strategies that they have been adopting at their center. Over to you, Dr. Ashima Dabas.
Yeah, thank you, Dr. Neeta, for this wonderful opportunity. And I think I would like to thank the Thalassemic Society of India and the organizers for having me here, even though at a short notice, but for a subject which is very close to my heart. So without much delay, I think I will like to begin. And before I begin, I would like to thank my former speaker, Dr. Poggi, for actually having laid a very solid foundation for what I would be discussing in the next 15-20 minutes or so. And as Dr. Neeta mentioned, I would be focusing more on our Indian experience of dealing with this complicated issue in children who already have a very complicated disease. So a part of it would be a little bit of repetition to what Dr. Poggi just mentioned. So I would skip that in the interest of time. But yes, overall, a little about what exactly constitutes bone morbidity in these children. What is the role of non-endocrine workup, which we do, and the endocrine workup, which is part of the disease management, and then the management. So I think something very similar to what Dr. Poggi discussed, where we are focusing on multi-pronged attacks that are happening on bone health in these children. And it is not just the disease that we are managing, but we are managing a whole lot of associated things, including chelator toxicity, which has been implicated in some or the other forms of bone disorder. We are also, I would really appreciate my former speaker for having highlighted the role of how lifestyle is actually contributing to a low bone mass overall in terms of reduced physical activity and changing lifestyle that we see, which earlier we were not seeing. And not to mention, and not to forget the endocrinopathies and the role of vitamin D for sure. So our presentation, the way we see patients mainly with concerns of bone would be ending up, they may just come with complaints of poor musculoskeletal health, where they may be complaining of vague bone pains, not feeling well, not really up to the mark for doing physical activity. A proportion of them do complain of bone pains, which I will be discussing in the cases where we have worked them up. yes, risk of fractures is there, but usually these get detected on annual surveillance. And as Dr. Pogi mentioned, the role of DEXA screening, as per the guidelines, we do follow those screening guidelines, but not very at a very young age. But as they start growing up, the need for surveillance increases, and depending on the logistics and the availability, we would be offering them the best of what is possible. A proportion of them also come up with chronic arthritis, and this is, I will again be sharing our work where this was a chance finding where children now have developed as they are growing into adulthood, as they are being handed over to adult physicians. The problem of where their transition of care has to be completed, we realize that a lot of them also have started developing arthritis, which is limiting their musculoskeletal movements and is actually adding a toll to their quality of life. Not to forget the endocrinopathies. And when we mention endocrinopathies, we are not just mentioning the parathyroid axis and the hypogonadism, which we very often screen and treat, but also not to forget is the third major player, which is insulin resistance. We understand that children with hyperferritinemia may end up with insulin resistance, and as implicated in type 2 diabetes, a disease which is very familiar to us, this may be an additional toll on the developing bones. So this becomes a major confounder of adverse bone health, especially in growing children during peripubertal years, where as such insulin resistance, they may be prone to a worse effect of insulin resistance. So I would directly talk more on management principles here in our group and what we do. So the first and the foremost part of managing bone in any child with thalassemia is the non-endocrine workup and the non-endocrine stabilization. So as the audience would be very familiar with how we manage treatment, so maintaining transfusions, serially monitoring a good hemoglobin, reducing ferritins, and all these have their own crosstalks with osteoblasts and the bone microarchitecture. Also important to emphasize the role of diet and nutrition. I am very happy that the role of even calcium supplementation came up, and this is exactly what I've put up. The calcium is not very robust. The amount of calcium is not robust in Indian diets, and at least our patients don't consume calciums enough to accommodate for the daily, even the estimated annual requirement of say 800 to 1000 milligrams of calcium that they need. So we do need to supplement them with calcium. And I agree with Dr. Pogi that yes, calcium carbonate being a cheaply available and cost-effective supplementation is often prescribed. Vitamin D supplementation also, I would agree that yes, we do fancy cholecalciferol, but a fraction of them would need the active vitamin D very soon, not to forget the micronutrients. A mention about the bone and the muscle crosstalk. So any exercise, any physical activity is going to improve muscle strength, more so in the peripubertal years, which is the which is the period of the maximum bone growth. So this is something that we do emphasize in all our patients. Point on protein intake. So in consonance with low calcium in the diet, protein intakes being low are very, very commonly seen in Indian diets, more so in children who are from the lower socioeconomic class. So this again has to be emphasized in all these children. So this I just put up to mention the how we are actually wanting to analyze further these complex dynamics of the molecules that we mentioned. So we are actually wanting to balance a state of a bone formation where osteoblast and osteoclast both would be affected by different triggers of disease that we see in thalassemia, in children with thalassemia. There are various factors, the growth factors, which get modulated and get differently expressed in disease conditions. And most of the studies, if we read in terms of systematic reviews, etc., have measured and have compiled of what would happen in bone turnover in thalassemia. So as for clinical experience, we don't routinely measure them. We are not measuring the bone turnover by any of these markers. But please remember, all these markers and these functions will in turn get affected by inflammation per se and nutrition, growth, and hormones. So with this background, if we understand why we do the endocrine workup and what are we wanting to stabilize, very, very important is the role of growth monitoring. A poor growth catch-up is not going to be very, very conducive for a good bone outcome. So growth, the role of IGF-1 as such, the insulin-like growth factors, which itself can have a direct and an indirect action on the bone osteoblast and would be in turn affecting the overall bone mass. Puberty. So puberty monitoring becomes very, very important in our settings, and do not like delay the induction of puberty if it is not happening spontaneously. Calcium phosphate ALP have to be measured. Serum vitamin D remains the most handy tool that we measure and we treat. And the recent systematic review also reported that despite being on regular supplementations and under follow-up, almost 60% may end up being vitamin D deficient. So yes, we may be targeting a vitamin D which is around 20 nanogram per ml. So at least 50 nanomole per liter, as Sir said. PTH levels we do monitor because we end up seeing a mix of both primary and secondary. Primary hypoparathyroidism, which is as per the disease and the effect on the axis. And we may also end up seeing a secondary hypoparat sort of a condition where the low vitamin D and the low calcium is actually worsening the bone profile in terms of a secondary hyperpara. So either of the two extremes is detrimental to bone health, ensuring that the thyroid functions and the insulin resistance stays in control. So this is our experience, where we recently evaluated the bone health in children who were being treated at our center at Maulana Azad Medical College. These were 40 children with a mean age of 14 years. So we had an age range of, say, I think almost from 8 to 18 years of age. We did have a bunch of them with associated comorbidities, and a few of them had been those who had not been very compliant with the transfusions earlier. But yes, those with hypoparathyroidism and hypogonadism were on regular replacement therapy. The only satisfaction was looking at the vitamin D status, where we did find that being on that monthly cholecalciferol supplementation, most of them were able to maintain a vitamin D level of more than 20. And we did evaluate bone turnover marker, which was the osteocalcin, as part of a research work, where we saw that those who maintained better hemoglobins and better B transfusion hemoglobins had better osteocalcin levels. So all of these would be indirectly would affect how their bones would ultimately grow. But what was very striking to us, which we had never realized earlier, was the effect of their bone architecture in terms of bone pain, arthritis, etc. So these are just few of the striking X-rays that I am putting up, where if you see that they per se perhaps did not complain of any localized bone pains or bone aches, but when we screened them, we realized that there were some random bony islands. We did have a proportion, almost 5 of them had an absent scaphoid of one of the either side of the bones, and probably this has been reported earlier in literature, perhaps related to a chelator effect, though we don't have a convincing pathophysiology as to what this happens, but this may also be a result of chronic hypoxemia, where this may be affected. So hip pain, a lot of these patients actually complain of hip pains and limited joint mobilities and limited physical activity when we screen them. So this hip X-ray actually shows a lot of cortical irregularities, sclerosis, and actually early femoral avascular head necrosis. So all this is probably burden of transfusion that we are seeing here. So we understand that beyond just an endocrine or a vitamin D axis that we are studying, we are looking at bone marrow expansion, osteopenia, desferrioxamine-induced skeletal changes, and definitely iron toxicity. Further on, in patients who had mild bony deformities, so for example, this is one of our patients who actually had genu valgum despite being corrected for vitamin D and calcium deficiency, a flattening of tibial condyles. So all this is going to add to the adverse quality of life, where movement, mobility, and outcomes later is going to be affected. This is one of the 17-year-old patients who complained with severe ankle pain, and to the tune that he had also almost become bedridden and was using a wheelchair to come for his monthly follow-ups. And when we worked him up, we realized that he had a lot of arthritis in the subtalar joints. Ultimately, this patient was operated. They did an arthrodesis, and this patient was also then shifted on medical management for his hypoparathyroidism, because it was not getting control only on calcium and vitamin D. So he is on teriparatide. He underwent corrective surgery for first one ankle at a time, and now at least he's mobile, like mobile on his own. This is another of our patient who was who showed a reduced who showed an old treated fracture, again severely affected with hypoparathyroidism and hypocalcemia, and was one of those required bisphosphonate therapies. So that being our most severe of the patients whom we had evaluated. So if I was to give a snapshot of what do we do in terms of evaluation of secondary osteoporosis in children. So this is the landmark recent paper from Dr. Ward and group from published in 2024. And as they mentioned, for all the indications for which secondary osteoporosis needs to be screened in children, thalassemia is unique because it does have it itself is a critical illness, has many associated endocrinopathies. Children are on medications which may be putting them on risk and obviously exacerbating lifestyle. So repeated transfusion, repeated hospital visits, they may not be the best in the best of the state for carrying out the physical activities, etc. So as per the guidelines, which are very clearly mentioned and laid down by the International Society for Clinical Densitometry, a DEXA in all these children who are at a higher risk of secondary osteoporosis needs to be done after at least every 2 years of age, after 10 years of age. If you ask us the sites to be ordered, a standard DEXA could screen the whole body, the spine or the hip. Please remember, in children, it may not be very prudent to choose a site per se. And that is why most of the pediatric DEXAs would be ordering the whole body minus the head for most condition. The spine the spine is basically measuring the trabecular mass. So trabecular mass, and while the whole body would be measuring the cortical, most of the cortical bone, and it is the hypogonadism mainly which is going to affect the trabecular bone. So in a child with thalassemia, it is not just the steroid or the growth axis which is affected. It is probably a composite mixture of many insults that can happen on the bone. So it is prudent that we do the whole body. We would want to use the age appropriate Z scores. So we are not wanting to use the T scores for the adults, but the Z scores for the pediatric population, which are age and gender appropriate. Again, please use the Indian data sets. So we have enough Indian data sets for the Indian children, and they are calibrated for the machines where they have been used. So also acknowledge the pubertal status of the child. So a child with delayed puberty and 14 years of age, the bone mineral density will not match that of a healthy control of 14-year-old who's in puberty. So that correction has to be done when we interpret the report. And the same equipment. So if it is a holologic, then the same equipment has to be used for serial monitoring of DEXA. We do have some other measures for assessing the bone, which is the vertebral fracture risk score and the trabecular bone score. Again, these are not very commonly available or commonly done in the Indian settings, at least. So I think I can skip the IACD guidelines for interpretation of DEXA reports. Most of it is what I just mentioned there. So if we talk of management, so in continuation with Dr. Pogi's talk, we are wanting to manage the primary disease. So optimizing care in all forms and in all principles is important. A very important role on nutrition. Ensure that they eat the right calcium, they get supplemented with it, encourage protein intake diet, limit the intake of junks and carbohydrate-rich foods in these children, advise on muscle strength. So very rarely do we emphasize on the role of doing isometric exercising and muscle strengthening exercises, but a simple exercises can be a good morning walk, could be some isometrics that they do. And yes, encourage active vitamin D supplementation. I will just mention the role of bisphosphonates, which have been covered by Dr. Pogi again, but the oral agents may not be very well tolerated and very efficacious in pediatric age group. The teriparatide again remains to be used in those who developed hypoparathyroidism, which needs a supplemental agent like this. So from the guideline papers, what we understand, for all patients who get detected with osteoporosis, we would want to correct the nutritional deficiencies, check for any other causes of secondary osteoporosis. And in thalassemia, it becomes more challenging because they may have a mix of hypogonadism, hypoparathyroidism, which are adding to the bone disease burden. So please check that, correct that first, and then evaluate the child's potential for spontaneous recovery from bone fragility. So if he is an under-transfused child, we would want to optimize the transfusions first. If he is not good maintaining a good calcium diet, then we would want to correct the hypocalcemia first. And then we would want to assess whether this child can be considered as a candidate to be offering a medical therapy, which is the bisphosphonates. And once we decide to use a bisphosphonate, which should be an IV agent, as Sir had also shown in his work of in his slides, where zoledronate or pamidronate remain the most frequently used agents, we would be then achieving a stabilization dose and then monitoring these children over a period of time. So I will not talk of many newer advances and therapies that are there, but I think we have a whole bunch of questions which Dr. Neeta has prepared, and I think we can steer the discussion around those questions for further inputs. So I will just end with these messages of in what we can easily achieve with all these factors, and not to forget what Dr. Deepak had earlier mentioned was the role of having people who can talk about all this and can screen and manage all these together in a child. So we actually need a good hematologist, a good pediatrician, a good musculoskeletal person, a good orthopedic person. All these have to now start talking to each other, coming together, that to ensure that all children get the best of the care. Thank you.
Thank you, Dr. Ashima, for that wonderful description of patients encountered, what are the pathophysiological issues that we see, and how do we manage, and especially focusing on how important protein supplementation is and the role of other comorbidity and the other endocrine abnormalities that you commonly see in this cohort of older thalassemia patients. So now we have a case discussion session. I think we'll take all the questions together at the end. So I would request Dr. Sudipto Bhattacharya, who is to share the slides. Dr. Sudipto is a fellow in pediatric hematology oncology at our center. So we actually looked for patients who had bony morbidity. And so thankfully, we didn't have any fracture recently. So we ended up selecting three patients, as in they're not children anymore. So they are three old adolescents and young adults with bony pain. So it's same symptom that you can see, but the extent and the severity is different. So there are three patients we'll be discussing, and I would request Dr. Sudipto to share the cases, and then after that we'll have a quick discussion. And I would request the ECHO team to kindly pin the experts so that we can discuss after each case. Over to you, Dr. Sudipto.
Good evening. Thank you. Thank you, Neeta ma'am. And thank you, Team ECO, for giving me this opportunity to discuss these cases. And so I would like to begin. So the first case is a case of well-managed transfusion-dependent thalassemia who had presented with low back pain. She was a 17-year-old girl. She was transfusion dependent, and she had issues like iron overload, pre-diabetes, and uh, sorry. Hello, am I audible?
Audible, yes, but we can't see you. Please continue.
Okay, and the screen is
Yeah,
not
it
visible?
is. Yeah, the screen is visible, but you need to put that on a slide share. You just stop the share again. Now it's fine.
Okay. Thank you.
Thank you.
So just 17-year-old girl, transfusion dependent, had this iron overload and pre-diabetic, and she was also having vitamin D insufficiency, and she had a history of hepatitis C in 2025. So she was on regular transfusion. 2 unit PRBCs were being transfused every 4 weekly. Good pre-transfusion hemoglobin was kept around 9 to 10. She was on deferoxamine and desferoxamine, chelation, deferriprone, had to be stopped as she had an episode of agranulocytosis. So this was the growth parameters. As you can see uh, that the height for age was lying around the median, and the weight, that is the BMI for age, is also lying around the median. She started complaining of low back pain for last 2 to 3 weeks, and she was able to ambulate, and there was no difficulty in regular tasks. So examination did not reveal any neurological findings. Power was 5 by 5 and in both lower limbs, and there was normal tone. This was the MRI T2 star findings. So she had a cardiac T2 star of 39.8 ms, which was showing a normal myocardial iron, whereas a liver T2 star was 2.99, which indicated a moderate iron overload. So HbA1c was 6.7%. Thyroid profile was normal. Vitamin D levels were insufficient, 23.6 nanogram per ml. She was started on calcium supplementation. So I would like ma'am to, Neeta ma'am, to ask the questions.
Yeah, so I'd like to start with our, as in a basic question to our experts. Like when a patient complains of low back pain in a thalassemia setting, whether it is transfusion dependent or non-transfusion dependent, what are all the considerations that you would keep in mind? Dr. Pogi and then Dr. Ashima.
Thank you. And I think that is really important when such a kind of patient presents with a backache, because from an endocrine point of view, we need to exclude the possibility of a fracture. We saw in my presentation that a clinical fracture is an event that could be present also at a very young age. And I think that is something that we have to exclude, we have to investigate. I would like to do a questions to the colleagues about the gonadal status.
Sudipta. So this is a girl who is in regular pubertal development and has she's not been evaluated specifically for gonadal status, but she's had attained menarche and regular menstrual cycles.
Okay, and just a little tips about. I'm sorry, but I'm endocrinologist, and I sometimes I fear about the use of HA1C, because it could be not so good as tool to differentiate the different state of pancreas impairment. We face with many patients that with a good level of H1C show with a different solution like fructosamine or like albumin glycated, a different and worse state of pancreas impairment.
So, Dr. Ashima, what would you regularly do in your practice? Like at our center, say I'm talking from a hematology perspective. So, we are advising a fasting blood sugar and an HbA1c.
Yeah, so I
So
would
what
agree
would
with
you
Dr.
advise?
Pogi.
Yeah.
Yes, ma'am. So I also do not do the HbA1cs, but I do the fasting plasma glucose and annual OGTT is what is the recommended guideline. And the reason why I'm emphasizing on the role of a 2-hour post glucose load glucose profile is because most of these patients have a lot of hepatic iron overload. And even if your MRIs are screening them well, sometimes the earliest change that you get is in the postprandial liver handling capacity of glucose. So I would suggest that you may continue to do HbA1cs if that has given you any additional any benefit, but include a 2-hour postprandial glucose also. We have some initial data of the use of continuous glucose monitoring in these patients. So, I mean, that data is very novice from most parts of the world where this technology has just become available to most. So maybe that can also detect the excursions that happen with meal. But I think coming back to this patient, where I agree with Dr. Pogi, we would want to optimize the other things that are going around with this child before we jump up to a screening. And I think before, what I probably missed in my session also, before you order a DEXA, it's very important to get a good X-ray of the lumbosacral spine in the correct posture to see whether the posture is correct, whether there is any exaggerated lumbar lordosis, which can happen in these patients who do not have a very good lifestyle, and it may be just it may just benefit with a good stretching or a good orthopedic consult instead of, it may not be osteoporosis at all. So
Yeah.
think of commoner things before we go on to the rarer things of a vertebral fracture.
Yeah.
Over.
Thank
Yeah.
you. So an X-ray was taken, and I think the DEXA happened after that. The X-ray was normal, and hence it was not presented. So to the next question, Sudipta. So like this, I think we have briefly discussed both the speakers. In a patient who's been followed up regularly, what is the skeletal surveillance that you would advise? Patient, asymptomatic patient, what is the current recommendation for skeletal surveillance? Dr. Ashima first and Dr. Pogini. Indian
ma'am.
as well as international guidelines. Yeah.
So the guidelines do mention a once in 2 year surveillance by the DEXA, at least after 10 years of age, and more aggressively in the peripubertal age where they're at a higher risk of osteoporosis. In practice, if you ask me, I don't have a facility for DEXA to be doing that often. But yes, if any patient, as in your case, presents with any suspicion of a back pain or any other marker where I know that he's at a very high risk of osteoporosis, I would add that to my armamentarium of an annual screening at least.
Dr. Pogi,
Yeah.
in an asymptomatic patient, what should we be doing regularly? So I think there are few patients also who are in the group, so it would be nice for them also to understand how they should be
Yeah.
screening themselves.
Yeah, we usually do a DEXA scan every 18 months, 2 years. But even if the general situation is good from an endocrinological point of view, because we have to remember that anemia and hypoxia is still important for the bone status health. In this case, I saw that there is a good general status regarding endocrine health, but bone health could be also impaired.
Yes, thank you. And next question is regarding vitamin D3. So this girl, so this is very common in our scenario. We are supplementing vitamin D3 in the recommended doses for supplementation. But still, when we evaluate for backache, we end up seeing some deficiency. So what is the current recommendation for a thalassemia patient? Is it like, are we to give a higher dose, or is it the same dose? Or are we to give vitamin D3 regularly? What is the current recommendation? Dr. Pogi?
Is in my experience is a little bit difficult obtain a good adherence to vitamin D therapy by patients. We see in papers, in guidelines, that the best way should be a daily dose to supplement, but try to fix a good situation between adherence, between what we know from pathophysiology. Usually we supplement by vitamin D at the dose of the 25,000-30,000 per week, or every 15 days.
I didn't get it. 25,000 per week.
Yeah.
Okay. So, so in India, we have the dosing available either as 60,000 international units, which is available as capsule or sachet, or we have like drops as 800 IU. So, what is the recommendation? How would you give, Dr. Ashima? Should we give bolus dosing? As in, should we give once in a year? Should we give 10 doses and finish it off?
Yeah. So, ma'am, what I practice is giving a monthly dose of 60,000, because our diets are not, so our sources are not very, there are hardly any dietary sources of vitamin D, and the sunlight also cannot be relied upon at all. for making enough vitamin D, and these are children at higher risk of osteoporosis. So a monthly 60,000 supplementation regime works very well for us and maintains vitamin D levels in the sufficient range in most. The compliance is better than the daily dose. It is cheaper and more cost effective. So giving a 60,000 is any day more if cost effective than a daily or a weekly dose. I agree with you that we don't have many preparations to experiment upon, unlike the other countries where they have simpler, like they have a 5,000 or a 10,000 IU preparation also available. If that was available with us at a relatively cost effective price, any day that would be better than a bolus dose, which is a 60,000. But in the current scenario, what works like decent for us is a 60,000 supplementation strategy. And I may omit the supplementation for a few months, in which I know that the child is going to be in a very sunny environment, like the May and the June that we have in Delhi. But otherwise, I would, for the sake of compliance and maybe uniformity, I would keep it as a monthly sachet to continue throughout the year. Yeah.
So another practical doubt. So we all start with vitamin D3 from diagnosis, right? We are starting at 800 IU per day from diagnosis. When do you switch to this 60,000 per month? Or like when do you increase the supplementation? The dose.
So ma'am, there are two, so we would be getting a baseline vitamin D done at some point when we are screening these children, maybe in around peripubertal period. I do get the vitamin D done as a part of with the calcium when I'm doing that. And sometimes the vitamin D level, if it is very low, and if the child is when they claim to be taking a vitamin D supplementation daily, and I get a vitamin D level which is just 3 or 4 nanogram per ml, I know that they have missed their dosing and perhaps they are not very compliant. So if the child is deficient would be less than 20 nanogram per ml in a high-risk child like thalassemia, I would go on to a treatment regime. The treatment regime would be a weekly or a bi-weekly vitamin D of 60,000. That I would complete for a total of 3.6 or 6 lakh international units, and then switch to a supplementation of 60,000 per month.
Okay.
And with that added calcium, which has 250 IUs of vitamin D, which is just that bare minimum vitamin D which is needed for that calcium to get into the body.
Yeah,
I
so
hope that answers.
Important for even trainees who have joined in, that calcium, which has a small dose of vitamin D3, would not be enough for our daily allowance as well. So that has to be given separately. So now coming to DEXA, I think both the speakers discussed about bone mineral density. So I'll start with Dr. Pogi. When you order a dexamethasone, what is the recommendation? What is the recommendation to do dexamethasone? Is it like whole body or is it site specific? Because we have many centers which offer 3 site specific DEXA in thalassemia patients. And which are the sites which are known to specify, as in, is there any prognostic, as in this site will predict a fracture risk more? Is there some correlation like that?
As an adult endocrinologist, when I order a DEXA, usually we order a DEXA that give us the results at lumbar and neck site. But I know that in young patients and children this is not the case. Shima could give us more information. I usually use not the whole body is not good information. Whole body, DEXA whole body could be useful in nutritional evaluation of the patients. And when I see the DEXA examination, I try. Obviously, lumbar site is more important, especially in the situation around 50 years of age. But we have to consider also the neck site that could be really important, especially from the quality of life of the patients if show a neck fracture.
And in children, Dr. Ashima, what are the kinds? And if you could briefly tell us T-score, Z-score, and from what age are you starting bone mineral density testing?
Yes, ma'am. So as Dr. Pogi mentioned, as per the ISCD guidelines, DEXA is indicated for any child more than 10 years of age. We may not be very sacrosanct in doing it at 10.1 or 10.2 years of age, but yes, around peripubertal age where I have corrected the other comorbidities, I would be wanting to screen with with a DEXA scan for osteoporosis. I agree that whole body is not very feasible, not very cost effective, and sometimes what we are looking at is the trabecular bone mass, for which spine is a very good image, but a spine and a hip would be easier to get done. So for most of the patients where they would be getting a DEXA done from an outsourced lab or a outsourced machine, then the spine and the hip would do okay for us. But the whole body does have a role in children, younger children. So I would say those who are pre-pubertal or peripubertal, where the whole body would give me sometimes a better indication. But the whole point about interpreting DEXA is the biggest challenge, where the even the Z scores that get calculated by the algorithm that the machine uses may not be the correct or the accurate ones for the Indian population. So the software that the machine may use may be still dependent on the Caucasian data. So a lot depends on how you interpret those BMD values. And that is why I'm again and again referring that it is not very simple to just order a DEXA and get those values and start treating patients on a Z score. There are many, many confounders to interpreting that DEXA score. So please remember, it is age, it has to be age, height adjusted, pubertal adjusted, and corrected for the Z score for that population. So we have Indian charts where there are tables where they've given the Z scores of bone mineral density at hip, at L1, L2, L1 to L4. So all that chart has to be interpreted with the report that the equipment has generated for you, and not to forget the pre-analytical errors. So pre-analytical errors could also be a wrong position in which the child was lying down when the DEXA was taken. So that is why I think me and Dr. Pogi both would agree it is not about treating a DEXA report, but it is about treating a patient as such. So I think the focus or the take-home message for trainees here should be: do not chase the DEXA, because we do not know, perhaps the best, we may not be accurate in interpreting that DEXA. So base your decisions and clinical management on wholesome points rather than a single DEXA report. And to answer this question, that yes, it's a Z score. A T score I would use at any age more than 18 years of age, not before that.
So one this practical thing which came up, if an adult is very short, as in if an adult like 18, 19 years of age and is extremely short, that Z score would actually over calculate. No, would you
Yes,
depend like
yes,
right.
because it has to be height adjusted. So that BMD would be falsely high.
Okay, thank you.
I think that DEXA is a useful tool, but sometimes could fail, and the short stature is absolutely a problem in evaluating DEXA results.
Okay, thank you very much for clarifying that. We have a question in the chat. I think we'll take that before we go to the next question. So there is, if you have pain, backache, if a patient is presenting with pain, the question from I think it's Dr. Rahul. I'm not able to see my chat right now, but it is like, what is the analgesic that you would prefer in a patient with thalassemia? So just any thoughts from your side? Is it like regular paracetamol followed by opioid, or NSAIDs? What is the choice from?
So I can only share my experience. I may not be the best pain physician here, but I think the cause of that bone pain needs to be worked out very importantly first. Is it a fracture that we are dealing with? Is it actually muscle stiffness that we are dealing with? Or is it only hypocalcemia and hypoparathyroidism that we have? So my suggestion to you is, please do not rely on analgesics and going up on analgesics. You need to show to a person. So please go and consult an orthopedic surgeon for if your calciums, hemoglobins, everything is okay from the medical point of view. It is time that you go and visit somebody who can help you with assessment of the musculoskeletal system before you hike up the analgesic. Though, as Dr. Neeta mentioned, paracetamol is the safest and should do. But anything that does not get relief with the paracetamol, which you may not need very frequently, then that should alert you for a detailed evaluation. I hope that answers the question, Dr. Rahul.
Thank you very much. Now I'd request Dr. Sudipta to please discuss the second case.
Thank you, ma'am. So the case number 2 is an 18-year-old male child who was having a diagnosis of beta thalassemia major, and he was transfusion dependent. He was on regular red cell transfusion, and splenomegaly was there of 4 to 5 centimeter. Pre-transfusion hemoglobins was around 8 to 9. He was on calcium and vitamin D supplementation. So these are the growth parameters. So the height for age was around the median, but the BMI for age, he was less than -2 standard deviation. So he was underweight. So these were the ferritin trends over time. So around 1400 to 1600 range with one spike beyond that. So he was well chelated otherwise. So he was on regular chelation. Ferritin was around 1500. He was on deferasilox and deferiprone and was started on luspatercept 5 months ago under a trial. He came with complaints of severe low back pain. He was immobilized due to this pain, needed wheelchair. There was no tingling sensation and radiation of pain to the thighs and legs. There was poor response to paracetamol and other analgesics. But on neurological exam, power was 5/5. In the lower limbs, bilateral plantars were flexor, and DTRs and tone were normal, indicating a normal neurological exam. So we went ahead with an MRI, which revealed diffuse T1 hypointense and T2 hyperintense marrow signals. It was suggestive of marrow reconversion from due to coronary anemia. There was minimal L2 and L3 posterior soft tissue component, and there were small nodules at multiple levels. There was no evidence of cord compression or canal stenosis. A DEXA scan was performed on October 2025, early first week, which showed in lumbar spine Z-score of -2.5, femoral and whole body Z-score around -1.9. So we had interpreted these Z-scores as osteopenia and osteoporosis. We investigated him further with a PET CT scan. There was no FDG avid lesion in the spine and ruled out osteomyelitis or malignancy, as he was actually having severe low back pain. Thyroid profile was mostly normal, and TSH was 3.04. Vitamin D was sufficient at 54 nanogram per ml. HbA1c was showing a 6.1 value. So now I would request Neeta ma'am.
So thank you, Dr. Sudipta. So again, coming to this patient, so his X-ray did show diffuse thinning of the bone. So that part was there, followed by MRI. So now there was a soft tissue mass which was detected, and hence we transitioned him to an adult orthopedician, and hence all the other evaluations subsequently. So because they suspected tuberculosis at some point, malignancy at some point. So we leave all that. We'll just come back to the pain as well as the fact that MRI showed this kind of picture, and there was evidence of a low bone mineral density. So what are the endocrine contributors? So whenever we have a patient in this age group, like older patient as an adolescent, young adult patient who's coming with backache, so we briefly saw what are the endocrine abnormalities that we should be regularly looking for. So what would you advise in your follow-ups? Other than thyroid, should we be looking vitamin D3, calcium, phosphorus, alkaline phosphatase is something we regularly do. Other than that, should we be looking at parathormone levels? Should we be looking at gonadal hormones? So what is your advice, Dr. Pogi?
Yes, my advice is that it is absolutely really important to check for gonadal status. Testosterone, estradiol in female is the main factors for a good state of bone health. I didn't see how was the gonadal status in these patients. I don't know if I fail.
We haven't sent hormones here because See, that's the mismatch that is happening because
Okay.
he's China stage 4, and so we didn't evaluate him further.
Okay. Okay, but thank you. But yes, the gonadal status is absolutely really important, especially in these decades, because it's important to reach a peak bone mass. Other aspect that is important to stress is an evaluation of a GH HF1 axis that nowadays is a little bit problem also because we have not so many tools to investigate. There is no chance in Italy to use the GHRH. There is no chance to use arginine. We can also only use a glucagon test, but could be really important when there is a state of GH deficiency, start with therapy to improve the results of replacement therapy by testosterone or estradiol. An aspect that I think, I don't know if could be later in other questions, is really important also to stress the type of the replacement therapy, especially in female.
So anybody with the bone pain, adolescent child, as part of regular workup, you will be sending out gonadal hormones, testosterone, estrogen levels, FHLSH also. Is that right? Or just estradiol and testosterone levels?
No, I think that is important to check estradiol, it's important to check testosterone in males, obviously, but also pituitary peptides, because we have also to remember that there is a link and that is important to evaluate the source and the periphery.
Thank you. Dr. Ashima, anything to add on?
Yes, I would agree with Dr. Pogi of monitoring him for gonadal arrested pivotal development. So even though he is stage 4 now, it is very likely that he may now end up with a secondary hypogonadism like state. So testosterone works very well in boys, but in girls, sometimes measuring a single estradiol level may be very challenging because the assay itself is not very reliable. So I think in females, the corollary would be whether the girl is having regular menstrual cycles or not. And if no, then irrespective of whatever estradiol level she tests, we know that there is something wrong in the gonadotrophic axis. So we may have to put her actually on cyclical HRT for some period if the disease control is not very optimal.
Yeah.
Yeah.
So this
and
is
the PTH to be checked annually. Because
PTH also as part of regular workup, right?
Okay. Yes, annually. Okay. We would be wanting to do that annually.
Okay, thank you.
And sometimes, sorry, if I may just add for the sake of making it more practical, sometimes a PTH which is low normal in a child who is hypocalcemic or vitamin D deficient, that may be the first sign of partial hypoparathyroidism. So we are not really looking at a level which is below a cutoff of say X level, but sometimes an inappropriately normal PTH for a hypocalcemia should also alert for treatment of the same as hypoparathyroidism. Yeah, thank you.
And will an alphos also help in that scenario? Low, not so high.
Somehow, my experience is that even when they are in puberty, they aren't into a state where they show very good or robust ALPs. Somehow, I mean, maybe it's part of the disease, like a chronic bone effect, where I seldom see very highly raised ALPs, even though the PTH may be swinging to either of the sides. So yes, I will not say that it is not a good marker. It is one of the most easily cheapest and most reliable bone turnover marker that should be monitored.
Thank
Dr.
you.
Pogi would want to add something.
Yes, no, I would like to stress also the fact that we see a low level of hypoparathyroidism, but the data is changing in different countries. But it's important to stress that is a particular complication that need a change in the use of vitamin D. We have to use different vitamin D that in other situation. We can use cholecalciferol.
You have to use calcitriol, you mean, right?
Yeah. Yeah, absolutely.
Thank you. So here this child was, his pre-transfusion hemoglobins were on the lower side. It's like between 8 to 9, and there's a spleen around 4-5 centimeters. So when he comes with a bony pain like this, and there is expansion of the medulla, as in the rarefaction of the bones that are seen, what is the role, as in that could be because of the disease per se as well, because of the chronic anemia and medullary expansion. So if we increase the threshold, will it substantially help in this kind of bony pain, or you think it's gone beyond that scenario? So is there any role of increasing transfusion threshold to say 10 in this child? Dr. Pogi?
In reality, I have not so great experience in guiding the transfusion rate. I follow my colleagues that in the transfusional center give me an idea. I try to improve. I have no knowledge about this aspect.
Yeah. We try to increase, but it does not really help most of the times. So other than the bony morbidities that we commonly encounter, like deferriprone causing a bony arthritis kind of presentation, or patients on chronic desferrioxamine who have shortening of the height shortening with platybasia, what are the effects of, are there any effects of chelators on the bony morbidity per se, as in bone pain can chelators per se cause, especially if you are on multiple chelators? Dr. Ashima?
Yeah, so ma'am, I think I also have the initial data, which is, I mean, the personal experiences only from deferriprone, where they do complain of sometimes very severe bone pains, where a change of chelators does help. But I, I mean, in our series, we did see a lot of skeletal abnormalities, and when we went back and read, then metaphyseal changes in the hand bones is reported with the use of desferrioxamine. So I don't know whether that had something to do with the skeletal burden of disease that we now see. So perhaps yes.
Okay. And luspatercept, since he was on a trial, and now we have a few more patients. So there is a distinct worry about extramedullary hematopoiesis. So similarly, is there any issue with the bone, Dr. Pogi?
Yes, we hope. We hope that the use of luspatercept could help us in treating bone disease. Probably yes, luspatercept could improve the bone health, could have a positive effect, but at my knowledge, at the moment, we have not so many data about it. But probably yes, with its action on GGF-beta system.
Yes, thank you. So when do we start anti-resorptive treatment? So we are giving vitamin D3, calcium, vitamin D3, we test, we supplement, and now we have a report like this. So what level would you advise? Is it symptomatic as a symptom-based treatment, or are you going to advise at a particular level in adolescents and young adults? I'll start with Dr. Pogi and then Dr. Ashimas.
As I heard from Dr. Sashima, I don't follow strictly the Z score. Obviously, that if I face with a Z score of minus 0.0 is really important. But especially in very young patients, I usually try to follow all the clinical pictures that are score okay, but also the data of the patients in a really holistic situation. And the pain is important, but is important the endocrine status. And I think that to start a subsequent therapy, a therapy of second step like antiresorptive, we can not follow only the Z score level.
And what is the drug that you would choose at your center?
At the onset, usually we choose the biphosphonates, but also for reimbursement aspect. This is a great problem. The economic aspect that are linked to the possibility to use drugs is something that we have in Italy too. We have to change.
Okay. Dr. Ashima, what would be your drug of choice if you were to put them on bisphosphonates?
So our experience and then choice remains with the use of IV bisphosphonates. So initially, when zoledronate was not very easily available and was more expensive, the initial few patients got treated with pamidronate. But again, zoledronate now is very, very convenient, safe, almost cheaper. So it's a single shot injection over 6 months, 6 monthly. So it's easier for patients to give. It's safer. There is less rebound hypocalcemias that we see. So we've shifted all my patients are now on zoledronate, be it primary or secondary osteoporosis.
Okay. Yeah, because adult, generally, if you send to take an adult experience, or you take a consultation from an adult orthopedician or an endocrinologist, generally oral is preferred. That's why I put.
They are very happy with the alendronate that they prescribe monthly. And so some of our patients who got transited to the adult care, I mean, adult care in terms of out of our system and are there being seen by the adult orthopedic colleagues, they are on oral bisphosphonates. And then I don't interfere because then there's at least somebody taking care of that oral thing. But for children, at least the data that has been reported is of not very good bioavailabilities with the oral drug. So I still prefer using the IV, especially during periods of growth and puberty, where we actually want to optimize the skeletal outcomes.
And how long would you treat, Dr. Pogi? How long would you want to continue? Would you look for only symptomatic resolution, or would you repeat BMD?
Usually we try to treat for about 2 or 3 years and reevaluate, because we go is something in a similar way, but it depends also to the level of impairment of bone disease. But in a not so great situation, we tend to carry on 2 or 3 years and reevaluate.
Thank you. Dr. Ashima, practical question. When you are going to give zoledronic acid to your patient, what is the baseline evaluation that you would do just for trainees who have joined? How do you give the infusion? What do you watch out for when you are giving it?
Yes, ma'am. So once you are sure that you have ruled out other causes of osteoporosis and this child would benefit with a bisphosphonate therapy, we would want to stabilize and normalize the calcium and the vitamin D levels. At least these two should be normalized. In children who have hypoparathyroidism, there the choice of giving bisphosphonate versus teriparatide have to be weighed. So in those children, I may actually avoid a bisphosphonate because they are going to land up with a worse problem of hypocalcemia, and I may actually start them on teriparatide. But if I'm starting bisphosphonate, I would normalize the calcium in those who have a borderline low calcium. In some of the patients, we've actually given an IV calcium loading and then started the bisphosphonates. The bisphosphonate is available, like it has to be prepared in an infusion, has to be given slowly. There are reports of first dose, like not anaphylaxis, but first dose hypersensitivity response. So that needs to be monitored. And a serum calcium has to be monitored at the end of the infusion. So there is recent data where they have shown the safety and efficacy of zoledronate infusions when titrated to, when used in doses of up to 0.1 milligrams per kg per year. And the risk of hypocalcemia is actually not very great, but we do still monitor. There is a little dip that we see in calcium, which can happen, but not symptomatic. At least I have not had that experience of symptomatic hypocalcemias after these infusions. So they are pretty safe, tolerated easily. And we would want to re-emphasize these children to continue their supplemental calciums and monthly vitamin Ds when we discharge them.
Yes, and at what calcium level would you consider IV calcium?
So I, ma'am, sometimes do treat serum calcium of less than 8 milligrams per deciliter, which is the lower range of normal. I do like prep up with a little IV calcium so that they have enough threshold during the infusion. I mean, that experience is probably not with children with thalassemia, but more with children of OI.
Okay. And Dr. Pogi, anything to add from your side as in for calcium?
Yes, I usually not use calcium in my patients, but I try to fix an accurate anamnestic evaluation, try to have an idea about the data intake. Obviously, check calcium before start therapy and regularly check the going on.
So I have a query regarding that. In your slides, you had shown how dietary calcium is a good source. And so
Yeah.
when would you add a tab oral supplemental calcium? Like if do we just ask for like 2 glasses of milk a day? Or do we just ask for when do you add calcium? Because a lot of patients who come to us are on calcium tablets from a very young age. So this
Yeah.
is something which always I've thought about. And I saw your slides. I had this query. When would you add supplemental calcium? When you think that oral calcium is not good enough, or it's still hypocalcemia levels despite oral calcium, as in
In
diet?
both cases, absolutely.
Yeah, okay. And Dr. Ashima, anything from calcium supplementation?
So, ma'am, in my experience, it is diet. I mean, they don't consume that even 500 milligrams of calcium. So, when we say 2 glasses of milk, the glass could be very, very variable in size. The milk could be very, very variable in quality, and it may not be complied with 100%. So, even if I emphasize on that 500 milligrams of dietary calcium, but I do always supplement them at least with the 500 milligrams of calcium, oral calcium. So, I may come down on oral calcium supplementations provided their diet has gone better with calciums.
From what age do you give calcium 500 milligrams daily?
So usually after 5 years of age, till then, most of the children are under the control of like being fed by parents. So they do pretty well with dietary instructions. But once they are more than 5, and especially once they're adolescents, so around 10 years, I would want to supplement them with calcium, because even if they have enough dietary calciums, we would ensure that during puberty there is enough calcium to get into their bones.
Yeah. I think one last question on the age. At what age would you start bisphosphonates? Again, related to the osteonecrosis question. So, at what age do you start bisphosphonates, and from what age do you? It's teriparatide. What is the lowest age that it is approved for?
So I think teriparatide, the lowest age, I don't think it is approved for adolescents. It can be started only around 18 years of age. The patient in which I used was 17 and a half, who had the picture where I had shown. And that was also after consultation, because I knew that we are getting nowhere with his poorly controlled disease. He was on a very high dose of active vitamin D also, and yet this calciums weren't improving. So we had no choice but to start teriparatide. Coming to bisphosphonates, I may not jump very quick for a bisphosphonate therapy in a peripubertal age group of child, because in most of them, correction of hypocalcemia, protein, other endocrine abnormalities may actually help. So I am not very fancy of starting bisphosphonates very early. Yeah.
Dr. Pogi?
Dr. Pogi.
I totally agree. Wait for the use in very young patients with bisphosphonates. The use of teriparatide in very young patients is not so good. We have to wait the end of transitional age. And when the patients are very young, I think that the best way is to try to fix all the aspects related to the lifestyle and all the aspects related to the total and good hormonal compensation.
Thank you. We have 2 questions related to, so I think teriparatide we already discussed. Denosumab, we have 2 questions in the group as well, in the chat group as well, as in, are there any serious side effects is one question. And other is like, what is the recommended duration once it is started? Dr. Pogi?
Sorry, I didn't catch the question, sorry.
Sorry, denosumab.
Yep.
Are there any serious side effects?
Okay.
That is one question. Okay. And the duration of use.
About denosumab, we know that as in general population is a very good drug that we can use. The problems regarding denosumab is the moment that you have to stop therapy, because we know that is capable to induce at the stop induce a fracture in very frequent prevalence. I think that denosumab is a good choice, but usually I tend to prescribe later on during the history of the patient. Absolutely, is the problem related to the use of denosumab is the same of bisphosphonates. If we check calcium, vitamin D at the start, and so if we advise patients about dental check, about avoid smoking, about good oral care, I think that is a very good option.
Okay. And once you have given the zoledronic acid for like 2-3 years, and later in life you can restart, right? If you have a similar problem again, there's nothing preventing its reuse. I think that was one of the questions.
Yes, ma'am. Can be restarted.
So I think we will we'll leave all this and then we'll go to the last case because we're running out of time. We have 10 minutes to wind up. So Dr. Sudipto?
Yes, ma'am. So the last case number 3, is a case of beta thalassemia, transfusion-dependent phenotype with poor chelation, low back pain, and other endocrine comorbidities. So the patient was a 25-year-old female. She was transfusion dependent on regular transfusion since 4 months of age and presently receives 2 units of packed cells every 15 days. She was having chronic low back pain. It was gradual in onset and mechanical pattern and aggravated by standing and bending over. There were no neurological deficits. This patient also had primary amenorrhea. So physical exam revealed extreme short stature. She was having hemolytic facies and liver was 4 centimeter below axis, but there was no splenomegaly. So in the graph, it is she was having this less than the centile of the growth was less than 10 centile, but weight was at median. She was started on chelation at 5 to 6 years of age, and currently she is on deferriprone at 100 mg per kg per day, deferresirox at 40 mg per kg per day, although her ferritin was 9,507 nanogram, which was recorded in June this year. MRI T2 star findings indicated mild myocardial iron overload from normal myocardial overload over a period of 2 years, whereas she was having severe liver iron overload for almost last 2 years. So this was the DEXA scan which was done in 2023. So she was having a Z score of plus 1.1 in the L1 and L2. She was having plus 1.0. And L4 level, she was having a Z score of minus 1.2.
So we shouldn't be discussing a Z score. Like that's what we learned right now, right? Sudipto?
Yes, ma'am. Yes, ma'am.
T scores.
So T scores were minus 0.5 at L1 and minus 0.5 at L2. L3 was minus 0.9 and at L4 it was minus 1.8. So we concluded that she was suffering from lumbar osteopenia, which was most pronounced at L4 lumbar area. So DEXA scan was again done in August this year. So she was having a total BMD of 1.114 gram per centimeter square. Her T score was minus 0.1. And so her interpretation was that whole body bone density was preserved, but lumbar spine showed localized osteopenia. Her endocrine and hormonal profile revealed her FSH and LH were low normal, and anti-Mullerian hormone was 0.21 nanogram per ml, which revealed an extremely low ovarian reserve. So she was suffering from an hypogonadal state. There was low estrogen activity with reduced bone mineral density. So L4 osteopenia aligned with the focal mechanical low back pain, and pain worsened with standing and bending. There were vertebral weaknesses, but there was no radiculopathy, and mechanical and metabolic etiology was favored. So over to you, ma'am.
So again, in this patient, how would you manage this child, Dr. Pogi?
Yeah, it's a very bad case because we saw bad data about transfusion escalation that probably start not so earlier. And we saw also a higher level of ferritin and so on. From a neurological point of view, I think that it's important to start with a good replacement therapy with estradiol and later on progesterone. I think that considering the history, that is a really bad history, is also important to check for GH-IGF-1 axis to try a second therapy after the gonadal therapy to improve the results. And this is a case probably in which we can see how DEXA could fail because we have not so bad data regarding DEXA, but the situation probably if we perform with different tools, if we perform X-ray, I think that we can see a very bad situation regarding lumbar side.
Yeah. And how long after waiting with estradiol supplementation would you consider anti-resorptive treatment in her? Would you you see response with just treating the hypogonadism, or would you start anti-resorptive treatment along with this?
I usually never start two therapies at the same time because it could be a problem in terms of tolerance, in terms of also
time,
adherence.
Okay.
And but I wait. Yet I wait.
Yeah.
Almost
And
this month. We lose the moderator.
Yeah, I think I can't see Dr. Neeta. But I'll just continue with and agree with Dr. Pogi completely. So in the last case, even I would be a little anxious and over anxious to start HRT now because we've lost enough time if she's 25 years of age without yet going into puberty. I may be faster in building up her pubertal induction. So I may not be very slow in 6-monthly mini doses. I may be faster because we don't have much time with her. And the last part where of use of bisphosphonate, I don't think I will be using any anti-resorptive agent in this child. HRT alone would do magic that we are expecting.
Okay. Yeah. Thank you. Sorry for getting dropped
That's
out
okay.
of the call. Sorry. So I think that finishes our questions. We had a couple of more questions in the chat. Dr. Sudipta, could you read it out because I've lost my chat history?
Yes, ma'am. So question to the experts. There was a question. Okay, this question was already taken. It was recommended duration of denosumab. So what is the management for deferiprone associated arthropathy? This is the question to the experts from Dr. Jatan.
Yeah, so I would be stopping deferiprone and would be switching to another agent is what my practice is usually. Any comments from Dr. Pogi, sir?
I have no experience about arthropathy associated to the use of deferiprone. I can answer about the questions regarding denosumab that we use for about 3-5 years, and then we start with a reconsideration of therapy. In general population, this is to reassure our patient. In general population, we use generally denosumab until 10 years without problems. But probably a shorter period could be a best way.
So, Dr. Vikrant had a supplementary question. So, can we restart zoledronate after stopping once, 3 years?
Yes.
Yeah,
if need be, yes.
There's one more question on limb length discrepancy. I think that also is beyond an endocrine purview, right? And what are the causes of limb
Yeah,
length?
but actually, I would want to answer that, because when we ended up screening patients for our skeletal morbidity, we realized that there were few of them. One of them, whom I put up on the X-ray, was when we realized that they had developed avascular necrosis of head because of chronic hypoxia, perhaps, and that is the only, pathophysiology that we found in literature as to why are these patients developing AVN. So again, I would share, perhaps that patient was as badly or poorly chelated as the last patient that you showed, ma'am. So the cause of that discrepancy is not something which is very common, but has to be associated with a skeletal problem. So the ideal age of surgical intervention, I may again not be the best person to answer that. But if the AVN is painful, then I think the orthopedic colleagues would want to operate that early.
Yes. So I think with that we finish. So regarding the last case, we have a small cohort of patients. When I see, as in we don't see adults that often, but very once in a while we do see adult patients who come to us who are very well transfused. So they keep their hemoglobins in the range of 10, 10.5 and very well transfused, and they don't have a splenomegaly, but they're very relaxed about chelation because somehow they either don't do MR based assessments or they do just ferritin, and they're not very keen on, as in they don't get ferritins from good labs. So because of that, there are so many comorbidities after like 20 years of age. So it has to go hand in hand. So like you mentioned, like chelation has to go hand in hand with transfusion if we are going the traditional route of managing. So I think with that, we come to the end of this very, very interesting, very, very informative session. I really thank Dr. Pogi and Dr. Ashima Dabas for taking the time out for this, for teaching us how to manage bony morbidity in thalassemia. And this is something which is completely overlooked. And this is, if we were to do like a thesis, if we'd like to do screen systematically all our patients, I'm sure we'll be diagnosing way many more patients than we actually are. And again, I would like to thank Dr. Ashima for stepping in the very last minute. So I think she was told to join around 12 o'clock in the afternoon, and like 6 hours later, she has a fantastic presentation and answers to all
Absolutely.
our questions. Wonderful, wonderful. Thank you very
Yeah.
much. And
Thank you to
Thank
you
you,
all.
Neeta, ma'am.
we will keep
Thank you.
disturbing you for future sessions as well. And we have a lot of lined up sessions for other endocrinopathies as well. So I will connect to both of you for that. And I would like to thank Thalassemia International Federation for suggesting the best speakers to us and for hand-holding us through these sessions. And to Thalassemics India for all the logistic support, and to Eco India for being helpful. All these are recorded and they go on a YouTube channel of Eco India called Advanced Thalassemia Webinar Series. So for each of the topics that we are doing, I think it's a wonderful learning resource for all all the students and all of us who keep seeing these children. Thanks again, and bye-bye to all of you. Bye.
Thank you again.
Thank you for mutual learning,
Bye.
Dr. Neeta and Dr. Pogi. Yeah, I enjoyed myself. Thank you. Thank you for the audience.
I enjoyed too. Thanks.
Thank you, Dr.
Bye.
Sudeep.
Thank you so much,
Thank you.
ma'am. Thank
Thank
you,
you.
everyone. Thank you.